Okay, very good evening, everybody. Today we are going to talk about our microbiology. So far we have done a lot of things. So on that we have done the anatomy, physiology, biochemistry, pathology, anesthesia, and dermatology. Today our topic of interest is going to be your microbiology. So speaking about the microbiology is one of the subjects where you can score plenty of marks, people. Plenty of marks. Like if you know there are simple algorithm and there are a lot of memory stuffs. So if you have understood these two things, then you can score a good score in microbiology. So speaking about the microbiology, how I have compiled this, I made a series of chart with the highlighted things. Okay, once you have understood the highlighted things and once you remember all the highlighted things, that is more than enough for the microbiology to score more than 50%. Okay, so first one is your culture media. Speaking about the culture media, so we are having a variety of culture media, people. This is quite a high yield one where you have to remember each and every point. Okay, so first one is going to be your culture media. So speaking about the culture media, before I want to proceed to the microbiology, I want whomsoever present here to acknowledge faster that if you could hear my voice and see the screen properly, type yes on the chat box. If you could hear my voice and see the screen properly, type yes on the chat box so that I can able to understand that you can hear me properly and I can proceed with the microbiology now. Okay, now speaking about the microbiology, the very first thing we're gonna talk about is your culture media. Is a culture media. What type of culture media we are having here? So first one is a simple media, and the examples of for each of them are pretty important and high yield thing that you should not miss it. Okay, first one is your culture media. So one is your simple media. The example for simple media is like a nutrient broth, nutrient agar, and peptone water. Nutrient broth, nutrient agar, and peptone water forms a simple media. And then you have the complex media. So what is a complex media? Ingredients are added as per the cultural characteristics of your organism. So what type of organism grows on what culture media? So as per the organism culture characteristics, the ingredients will be added. So apart from that, you may have the synthetic media, which is synthesized from the chemicals with a defined composition. For example, 1% peptone with the 0.5% NaCl in water. This is one of the classical example. Peptone media and 0.5% NaCl growth, you have to detect it. Whether you can able to detect the growth in the 0.5% NaCl or not, that is so called as a synthetic media. So now my question is, what is the organism? What is the organism which shows this type of a synthetic media? What is the organism which shows this type of synthetic media? What is the organism which shows this type of synthetic media? Where you see in the 0.5 NaCl. Where you see the 0.5 NaCl. Faster, people. Not in a 0.5. 6.5 NaCl growth is detected in Strep bovis. You don't remember Strep bovis. Bovis is growing in sodium chloride. Bovis is growing in sodium chloride. Apart from that, you have enriched media, where substances which has been added to the basal media to promote the growth of the organism. So a substance which should be added to the base medium. So there is a base medium and a substance which has been added in order to promote the growth. For example, blood agar. Blood agar, when you heat the blood agar, you get the chocolate agar. Apart from that, you have egg media where egg is added. And then you have the loftless medium. And apart from that, you have the enrichment media, substance which is added to inhibit the growth of the organism is so called as enrichment media. Inhibition of growth, enrichment media. And promotion of growth, it is an enriched media. Okay, example one is tetrathione growth and a selenite F growth. Selenite F growth is the one where you see the enrichment media, one such a classical example. Apart from that, selective media, only for, like a selective organisms. For example, like we have a LJ medium for TB, McConkey agar for Enterobacteriaceae, and DCA for Shigella. All those things are the selective medium. That is, only certain organisms will grow in that one particular point. Only certain organisms will grow in that one particular point. That is so-called a selective medium. And then you have an indicator medium, where as soon as the bacteria grows, there is a color change. That is so-called as indicator medium, where you may use to see the Wilson-Blair and Maillard media. Apart from that, you have a differential media to bring about the differential characteristics of bacteria, where you see the McConkey media for lactose fermenters, Apart from that, transport media, VR medium and the Stewart medium. So VR medium is the one which is used for the characteristic transport medium for your Vibrio cholerae, that you have to remember that. Okay, then what type of organism grows on what medium? Another important 5-star rated table that you should not miss, people. Another important 5-star rated table where you should not miss. One is your H. influenzae. So H. influenzae, it may grows in the chocolate agar. Media contains factor 5 and 10. The chocolate media contains factor 5 and 10. Factor 5 and 10. Apart from that, your Neisseria grows in the Thayer-Martin agar. So what is this Thayer-Martin agar? You heat the blood agar, you get a chocolate agar. And when you add a vancomycin on a chocolate agar, so chocolate agar, if you add the vancomycin on it, then you may get a what agar, people? We may get a Thayer-Martin agar. Okay, so this is a selective one for the Neisseria species. Okay, among the gram-positive organism will grow in the vancomycin, and gram-negative, except the Neisseria, will not grow in the like a Thayer-Martin agar. Okay, so next is a Bordetella pertussis, where you see the boarded Ganga agar and Reagan-Lowe medium, boarded Ganga agar and Reagan-Lowe medium. While the boarded Ganga agar contains a potato, while this one contains a charcoal and blood. Then you have a Corynebacterium diphtheriae, where you see the Terylite agar and Loeffler's medium. And the Mycobacterium tuberculosis, it's a LJ agar or LJ medium, which is a selective medium. And Mycobacterium pneumonia, you have a Eaton agar, which requires a cholesterol. And lactose fermenting enterics, it may grow on the McConkey agar, and E. coli, eosin methylene blue agar. And apart from that, Legionella, you may see it in the charcoal yeast extract agar. Okay, which will be buffered with cysteine and the cysteine and iron. Okay, you have to remember that charcoal agar yeast, which will be buffered with cysteine and iron. Okay, so this is one among them. Important culture media. So speaking about the important culture media, Thayer-Martin agar is the selective media for Neisseria, gonorrhea, and meningitis. Boarded Ganga, Bordetella pertussis. Tellurite agar and Loeffler's medium is for diphtheria. LJ medium is for tuberculosis. McConkey agar is for lactose fermenting enterics, while eosin methylene blue is for E. coli, and Legionella is Legionella grows on the charcoal yeast agar. Okay, charcoal yeast extract agar. So these are the culture medias, important culture medias that you have to remember, people. These are the important culture medias that you have to remember. Apart from that, we need to know about the bacterial toxins, people. So speaking about the bacterial toxin, we divide the bacterial toxin into exotoxin and endotoxin, people. We used to divide the bacterial toxin into exotoxin and endotoxin. So what is the differences? You may see it in the exotoxin and endotoxin. So exotoxin means we may do the exotoxin here and endotoxin here. What is the difference between your exotoxin and endotoxin, people? So speaking about that first one, mostly it is secreted by gram negative. Mostly it is secreted by gram negative, while exotoxin is both gram positive and gram negative. Not all bacteria, certain bacteria. Both contain certain gram positive and gram negative. Here, certain gram negative one. And apart from that, mostly it will be a polypeptide one, while this one will be the lipid A of lipopolysaccharide. LPS will be the component here, and mostly it acts on plasmids. Mostly it will act on plasmids, while this one act on bacterial chromosome. This one act on bacterial chromosome, people. Chromosome. And apart from that, you may have this one is having a antibodies, which is so called as antitoxins, and this one is poorly antigenic one, which is not necessary nowadays. So speaking about the exotoxin and endotoxin, what type of exotoxin and what type of endotoxin we are having, which is quite important. Mostly our Indian microbiology books used to give the organisms, and they add the toxins along with the organisms. They add the toxins along with the organism, and most of the toxins are kind of like a super high yield topic in the upcoming examinations, because nowadays they have asked all about the clinical features already and culture medias already. So their question of choice here is more or less is now focused on the exo and endotoxins. Exo and endotoxin. So I made a separate chart for the exo and endotoxin so that you can able to master it in a very easy way. Okay, first we talk about the endotoxin and then we move on to the exotoxin, or shall we move on to the exo first and then goes to the endo next? And then we goes to the endo next. Which one you want to do, people? Anyways, we move on to the exo first and then we move on to the endo next. So exotoxins are basically classified mainly under 4 categories, people. Basically classified mainly under 4 categories. One is your inhibition of protein synthesis. One is your inhibition of protein synthesis. Another one is your inhibition of phagocytic ability, people. Okay, another one is the inhibition of phagocytic ability. And another one is the inhibition of release of neurotransmitter. And another one is your super antigen. So what are the things you are going to talk about? The exotoxins are broadly classified under 4 categories. What are they? Inhibition of protein synthesis, inhibition of phagocytic ability, inhibition of release of neurotransmitter, and super antigen, people. And super antigen. Now speaking about the inhibition of protein synthesis, where you see first is the inhibition of elongation factor 2. Where you see the inhibition of elongation factor 2. So speaking about the inhibition of elongation factor 2, we are having technically, we are having technically 2 organisms which can able to inhibit the elongation factor 2. One is your Carnibacterium diphtheriae, and the toxin name is your diphtheria toxin. Okay, one is your Carnibacterium diphtheriae, which contains a diphtheria toxin, which can able to inhibit the elongation factor 2. And then second one is your Pseudomonas aeruginosa. In the Pseudomonas aeruginosa, where you see the exotoxin A. Very important MCQ is your exotoxin A. Exotoxin A of your Pseudomonas aeruginosa will inhibit the elongation factor 2, thereby inhibiting the protein synthesis and thereby inhibiting the organism. Then apart from that, the one which act on the protein 60S ribosome, thereby removing the adenine from the tRNA. So when the tRNA is removal of the adenine could result in inhibition of protein synthesis. As we know, in the translation of proteins, where the tRNA bind with the smaller unit and then you have the larger unit, then it contains the A site, P site, and E site, where the jumping of a tRNA or transfer of amino groups to the one to the another tRNA could result in the synthesis of your chain of amino acid, which is your primary structure of protein. Yes or no? Now we are inhibiting it. How? One is by inhibition of the elongation factor 2. Another one is binding of the 60S chromosome. Binding of the 60S chromosome or inactivation of the 60S chromosome. So inhibition of elongation factor 2 is done by two things. What are they? Corynebacterium diphtheriae, which contains a diphtheria toxin, which can inhibit your inhibition elongation factor 2. Then you have exotoxin A by the Pseudomonas aeruginosa. Okay, exotoxin A. So diphtheria toxin and exotoxin A, diphtheria toxin and exotoxin A both can result in the inhibition of elongation factor 2. Next is your inactivation of your 60S ribosome. Speaking about the inactivation of the 60S ribosome, we are having two toxins, people. One is a Shiga toxin from Shigella. One is a Shiga toxin from Shigella. Another one is a Shiga-like toxin from EHEC. Another one is a Shiga-like toxin from EHEC. So both can able to inactivate the 60S ribosome. Both can able to inactivate the 60S ribosome. Then the next category is your increase in the fluid secretion. Increase in the fluid secretion could be either like a edema one, or maybe the diarrheal one, or maybe the vomiting one. Anything which can cause an increase in the fluid secretion in the body, that is so called as a fluid secretion toxin. By how? By increasing a cyclic AMP or cyclic GMP concentration. By increasing the cyclic AMP or cyclic GMP concentration. So how does it is producing the cyclic AMP and the cyclic GMP, and how does it is producing the enhanced enhanced fluid secretion in the body? So we are having a three types of toxins for the three types of toxins for the increase in the fluid secretion. One is your ETEC, enterotoxic E. coli. Another one is your Bacillus anthracis. Another one is your Vibrio cholerae. Another one is your Vibrio cholerae. All three act on cyclic AMP, except the heat stable toxin of your ETEC, which act on cyclic GMP. Okay, so they act on the cyclic AMP, but how does it is contributing for the fluid secretion? How does it is contributing for the fluid secretion? For example, activation of cyclic AMP could result in what? Increase in the chloride secretion in gut. Yes or no? Increase in chloride secretion in gut. Whenever there is a chloride secretion in gut is increased, then what happened to the H2O? H2O will be effluxed. Yes or no? H2O will be effluxed. When H2O will be effluxed, automatically what happened? Fluid will be secreted. Fluid will be secreted. Similarly, for a cyclic GMP, there will be a decrease in the reabsorption of NaCl. Decrease in reabsorption of NaCl. So since it is a decrease in the reabsorption of NaCl, as I said, wherever sodium goes in the body, there will be always be a movement of water. So sodium is not reabsorbing in the gut. So sodium will be in the gut. So wherever the sodium stays, the water stays. H2O will also be secreted, or H2O will also be reabsorbed, decreases. Decrease in the reabsorption of H2O also. That in turn produces more amount of fluid secretion. So first one, we have talked about the protein synthesis inhibitor. 4 toxins by elongation factor 2 inhibition is done by diphtheria toxin, and it is also done by your exotoxin A. Then 60S ribosome, Shiga toxin, and Shiga-like toxin. Shiga-like toxin by EHEC. Very, very important. Then fluid secretion, cyclic AMP and cyclic GMP. Cyclic AMP mediated by heat labile toxin of ETEC, the edema toxin of Bacillus anthracis, and the cholera toxin of Vibrio cholerae. And cholera toxin of Vibrio cholerae. And increase in that, you have the heat stable toxin of ETEC will increases the cyclic GMP. Both can produces the fluid secretion more. Both can produces the fluid secretion more. Then you have an inhibition of your phagocytic ability. Inhibition of your phagocytic ability, where suppression of your cyclic AMP will be there. So whenever there is a suppression of your cyclic AMP, there will be absence of your phagocytosis. So phagocytosis is absent, then automatically microbes cannot be removed. So it will produce a toxin. So one such classical example is your pertussis toxin by Bordetella pertussis. Pertussis toxin by Bordetella pertussis, very classical MCQ. Okay, Bordetella pertussis can produce whooping cough, right? Yes or no? And then you have a release of neurotransmitter. So release of neurotransmitter is done by inhibition of snare proteins. So inhibition of snare protein is done by two toxins. One is a tetanospasmin. One is a tetanospasmin, which is done by your Clostridium tetani, and another one is your botulinum toxin, which is done by your Clostridium botulinum. One is your tetanus toxin, another one is your botulinum toxin, which is done by your Clostridium botulinum. Okay, both Clostridium species can inhibit the snare protein. Both Clostridium proteins can inhibit the snare protein. And apart from that, the one which lies the cell membrane, by acting on the, phospholipase. So one is your Clostridium perfringens, another one is your streptolysin O by Streptococcus pyogenes. Another one is your streptolysin O by Streptococcus pyogenes. Another one is your Clostridium perfringens by alpha toxin. So alpha toxin act on the inhibition of phospholipase. So inhibition of phospholipase could result in the degradation of a tissue and cell membrane, and thereby reducing the Clostridium perfringens. Thereby damaging the cell membrane and production of the bacteria. Apart from that, streptolysin O, which can release the streptolysin O toxin, which is the protein that degrades your cell membrane. Then you have a super antigens, people. The last category we are going to talk about is your super antigen. So super antigen binds with the MHC complex 2 and a T cell receptor, thereby causing a release of your interleukin 1, 2, interferon gamma, and TNF alpha, and produces the shock. So there are two super antigen. One is your toxic shock syndrome toxin 1 by Staph aureus, and another one is your exotoxin A by Strep pyogenes. While exotoxin A by Pseudomonas is elongation factor 2 inhibition, exotoxin A by Streptococcus pyogenes is a super antigen, which can release interleukin 1, 2, interferon gamma, and TNF alpha. Okay, interferon gamma and TNF alpha. So far we have done the exotoxin, people. So shall we revise the exotoxin? So speaking about the exotoxin, we are having a 6 mode of action. One is your inhibition of protein synthesis, elevation of fluid secretion, inhibition of phagocytic activity, and inhibition of release of neurotransmitter, lysis of cell membrane, and super antigen. So inhibition of protein synthesis done by two mechanisms. One is via the elongation factor 2 inhibition. Another one is acting on the 60S ribosome. Elongation factor 2 inhibition is done by diphtheria toxin and exotoxin A by Pseudomonas aeruginosa. Okay, while 60S ribosome inhibition is done by two toxins. What are they? Shiga toxin and Shiga-like toxin by EHEC. Okay, then you have an increased in cyclic AMP concentration, which is done by heat labile toxin of ETEC, and then edema toxin of Bacillus anthracis, and cholera toxin of Vibrio cholerae. Then you have an increase in cyclic GMP, which is producing a heat stable toxin, where you see the decrease in reabsorption of sodium chloride and water, so that their water will be secreted out. Then you have a phagocytic ability suppression done by your pertussis toxin, done by your Bordetella pertussis, which is growing on Bordet Gangal agar, Bordet Gangal medium. Okay, then release of a neurotransmitter suppression is by inhibition of snare proteins done by two. What are they? One is your tetanospasmin, another one is your botulinum toxin. Both can be produced by Clostridium species. Tetanospasmin is done by Clostridium tetani, and another botulinum toxin is done by your Clostridium botulinum. Then apart from that, you have one which lies the cell membranes or your alpha toxin by your Clostridium perfringens. Another one is your streptolysin O by Streptococcus pyogenes. Then you have a super antigen TSST1 by your Staph aureus and exotoxin A by Strep pyogenes. Okay, both can bind with the MHC complex 2 and a T cell receptor, and both can increases the release of interleukin 1, 2, interferon gamma, and TNF alpha. Okay, these are the one thing which you need to know regarding the exotoxins, exotoxins. Then you have an endotoxin. So speaking about the endotoxin, so what are the things which can able to produce the endotoxins? So first one, endotoxin is via three mechanisms, either a macrophage activation or complement activation or tissue factor activation. Okay, three mechanisms. What are they? Macrophage activation or complement activation or tissue factor activation. So speaking about the macrophage activation, one is done by either a activation of IL-1 and 6, either a activation of IL-1 and 6. IL-1 and 6 is activated, then you may get fever, obviously. TNF alpha, again, fever along with the hypotension. And third one is nitric oxide, you may get the hypotension alone. Hypotension alone. Then you have a complement activation, which is your C3A and a C5A. C3A will produce a histamine release and C5A will produce a neutrophil chemotaxis. Then you have a tissue factor activation. Coagulation cascade will produce DIC. Coagulation cascade will produce DIC. Okay. Then this is all about the exo and endotoxin, people. This is all about the exo and endotoxin. Then what are the bacteria which is based on the shape? What are the bacteria which is based on the shape? One is your gram positive and the gram negative. Gram positive are, okay, we talk about the bacteria based on the shape, people. We are going to talk about the cocci, which is a gram positive cocci and a gram negative cocci. Then we talk about the, bacilli, where we see the gram positive bacilli and a gram negative bacilli. And once we done that, we have special bacteria. Once we done the special bacteria, then everything will be over, people. The bacteriology will be over. You have to remember that, okay? So the toxins is kind of like one of the pages where you have to read one day right before the exam, one day before the exam, not on the car. Remember, one day before the exam, you have to master this. And apart from that, this chart in the microbiology is kind of like your key factor, people, where I include most of the organism. Remaining organism, if I missed, you can able to add it up here. Remaining some points you feel like it is important, you can add it up here. Okay, I try to cover most of the points over here itself. So try to learn more and more along with me. So first one is your cocci. So based upon the gram strain, we divide the cocci into gram positive and gram negative, people. Based upon the gram strain, we divide the cocci into gram positive cocci and a gram negative cocci. Okay. Speaking about the gram positive, we can further divide into, you can able to get it, like these people can able to send you the images, the PDF. You can contact the admin for that. Okay. And then you have the gram positive. So speaking about the gram positive would be divided into catalase positive and catalase negative. The gram positive is further divides into catalase positive and catalase negative, people. Okay, we move on to the catalase negative later. First, we move on to the catalase positive. Okay, first we move on to the catalase positive. Speaking about the catalase positive, and we further divide the catalase with the coagulase inside. So coagulase further, coagulase positive and coagulase negative. Coagulase positive and coagulase negative. Mostly catalase positive ones are staphylococci. Mostly catalase positive ones are staphylococci. Among that, coagulase positive staphylococci are Staph aureus. So how do you describe the Staph aureus? It is a gram positive cocci with a catalase positive and coagulase positive. Okay, gram positive cocci with catalase positive and coagulase positive. So speaking about the catalase positive Staph aureus, what are the highlights you have to know in terms of your Staph aureus, people? What are the highlights you have to know in terms of your Staph aureus? First one is it can produce a protein A, which is a virulence factor, which can produce a protein A, which is a virulence factor. Very, 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 very important MCQ. Virulence factor is your protein A. Because this protein A can bind with the FC portion of your IgG, and inhibits the complement activation. Inhibits the complement activation and produces, okay, I'd rather write it here. Complement activation and produces phagocytosis. So this is the virulence factor. phagocytosis. Okay, fine. Apart from that, mostly it is colonizes the nerves, and apart from that, it is a beta hemolytic. So how do you call it? Gram positive, coagulase positive, catalase positive, beta hemolytic. Okay, beta hemolytic ones. Apart from that, it grows on the mannitol salt agar. Apart from that, it grows on the mannitol salt agar. Very, 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 very important MCQ. Mannitol salt agar. And in the apart from that, it may forms a yellow or gold pigment colony. The images have been added in the last. Let me show you the colony of your Staph aureus. Yellow gold pigment or yellow green pigment, which is seen in the mannitol salt agar and Staph aureus. And in the McConkey agar, it shows the pink colonies. The image-based questions are pretty important, people. Okay, image-based questions are pretty important. Staph aureus, you may see the yellow-green pigment seen in the mannitol salt agar, and you see the pink colonies in McConkey agar. You see the pink colonies in McConkey agar, which was not mentioned here. You can add it up here. Okay, pink colonies in McConkey agar, yellow or golden pigment colonies in mannitol salt agar. Then you have a TSST1 toxin, which is a toxic shock syndrome, which is a toxic mediated, and it is a super antigen. As we studied in the exotoxins, it comes under the category of super antigen. So what is the super antigen, people? What is super antigen? What is super antigen, everybody? So what is the mechanism behind the super antigen? It will bind with the MHC class 2 and T cell receptor and produces interleukin 1, 2, interferon gamma and TNF alpha activation, and thereby producing a shock. That's why it is so called as a toxic shock syndrome, where you may see the fever, rash and shock features. Where you may see the fever, rash and shock features. Okay, then you have exfoliative toxin. Exfoliative toxin can able to produce your scalded skin syndrome. Exfoliative toxin can able to produce scalded skin syndrome, and you know that Staph aureus is the most common cause of acute food poisoning within 6 hours. Within 6 hours after the consumption of food. So whenever they ask you, the patient has been coming from the restaurant, suddenly he developed a vomiting, nausea and diarrhea, and severe acute food poisoning has been noted. What is the most common organism? So for acute food poisoning, there will be two reasons, people. One, it could be either a Staph aureus, or another one is it should be due to the Bacillus cereus. One, it should be due to the Staph aureus, or another one, it should be due to the Bacillus cereus. So speaking about the Bacillus cereus, it should be they are be giving another important hint when you are talking about the Bacillus cereus. What is the another important hint they may give you? The very classical hint they may give you is either the patient has been eaten in the Chinese restaurant, or the patient had consumed a reheated rice, or the patient had eaten a fried rice, Chinese fried rice. So reheated rice syndrome is associated with the acute food poisoning, that in turn associated with the Bacillus cereus. So any acute food poisoning, what are the two organisms that should come into your mind? One is your Staph aureus, Bacillus cereus. Then immediately look for the question whether they had mentioned any sort of Chinese fried rice or not, or any sort of Chinese restaurant, or any sort of reheated rice was mentioned or not. If it is, then they are directing the question to Bacillus cereus. If it is not, then they are directing the question to your Staph aureus. Okay, then apart from that, Staph aureus is also most common cause of your acute osteomyelitis and acute endocarditis. Staph aureus is also one of the key features of your acute endocarditis and acute osteomyelitis. Acute osteomyelitis. So these are the important ones you have to remember, people. These are the important ones you have to remember. Okay. So apart from that, what is the drug of choice for the Staph aureus? The drug of choice is penicillin. For MRSA, the drug of choice is vancomycin. And for VRSA, the drug of choice is linezolid or quinaprestin. Okay, linezolid or quinaprestin, they may have mentioned you. This is the most common organism causing acute osteomyelitis and acute endocarditis, which is your Staph aureus. Drug of choice is penicillin. And you may have this drug of choice for MRSA, it is a vancomycin. And for VRSA, It is a linezolid or quinipristine. For VRSA, it is a linezolid or quinipristine. Okay, very important. Okay, so we have talked about the coagulase positive, catalase positive staphylococci. Now, what are the coagulase negative staph? What are the coagulase negative staph? So speaking about the coagulase negative, we can able to divide the organisms into two categories based on the novobiasin resistant. If it is a novobiasin sensitive, we used to call that organism as a staph epidermiditis. Okay, so what is a staph epidermiditis? Which is a gram-positive cocci with the catalase positive, coagulase negative, and it is a novobiasin sensitive, and it is appears in the clusters, and it is a urease positive. It is a urease positive, mostly seen in skin, nose, mouth, GIT in the patient. Skin, nose, mouth, and GIT. So any patients with the prosthetic devices, for example, like a hip implant or any heart valve implant or any IV catheter, then this patient is having a staph epidermiditis infection. And apart from that, subacute endocarditis and IV drug abuses, the organism which is causing a staph epidermiditis. Subacute endocarditis in IV drug abuses, it is staph epidermiditis, and you have the normal flora. So any prosthetic devices, then you may also think about the staph epidermiditis. The novobiasin resistant, which is a staph saprophyticus, which is causing a UTI in a sexually active adolescent. So sexually active adolescent. Mostly in FMGE, they don't ask you the questions regarding this. Okay, so but you have to remember that in the adolescent, whenever the patient is coming to you with the 25-year-old female with recently married and a history of honeymoon, having a burning sensation in the urine, then the most common organism apart from E. coli you have to suspect is your staph saprophyticus. Okay, recently sexual active female with the UTI or burning sensation in the urine, then you have to suspect. First one is a E. coli you have to suspect. Apart from that, the next organism you can suspect is staph saprophyticus, which is a gram-positive cocci and which is a catalase positive, coagulase negative with the novobiasin resistant people. With the novobiasin resistance, you have to remember it. Okay, clear about that? Clear about that? Shall I move on to the another one, which is your catalase negative catalase negative organisms. We have talked about the catalase positive, which is your staphylococci. We have talked about all the staphylococci. Shall we move on to the catalase negative organisms? Shall we move on to the catalase negative organisms? Okay, speaking about the catalase negative organism, people. Okay, speaking about the catalase negative organism, we can able to divide based upon the hemolysis, people. We can able to divide the catalase negative organism based upon the hemolysis. So we can able to divide it as a alpha hemolysis, beta hemolysis, and gamma hemolysis. Okay, alpha, beta, and gamma hemolysis. Okay, speaking about the alpha hemolysis, again another drug which comes here is the optocin sensitive and optocin resistant. So optocin sensitive one is your strep pneumoniae. Optocin sensitive one is your strep pneumoniae. What is a strep pneumoniae? It is a gram positive and it is a cocci. It is a catalase negative alpha hemolytic optocin sensitive one. Okay, alpha hemolytic optocin sensitive one. The most common one is your strep pneumo, and it is an encapsulated one. Since it is present in the diplococci, it is a diplococci, technically speaking. Gram positive diplococci. Okay, remember, gram positive diplococci is strep pneumo, while gram negative diplococci is your, what do we call it? Your Neisseria gonorrhea. Okay, your Neisseria species is a gram negative diplococci, while your gram positive diplococci is your strep pneumo. Okay, so whenever you think about the strep pneumo, what are the things you have to remember is, it is a lancet-shaped diplococci, people. It is a lancet-shaped diplococci encapsulated Pneumonia associated with the rusty sputum. Pneumonia associated with the rusty sputum in elderly patient. In elderly patient or splenectomy patient. Or splenectomy patient. Okay, elderly patients are splenectomy patients or sickle cell patients. That is not necessary for FMGE. Okay, so for a lancet-shaped diplococci encapsulated pneumonia in pneumonia with rusty sputum on over 60 years or splenectomy patient. Apart from that, there are 4 words you have to remember. I used to remember with the mnemonic of SMOP. I used to remember with the mnemonic of SMOP. SNOP. S stands for sinusitis. Sinusitis. M stands for meningitis. Meningitis. O stands for otitis media. Otitis media. And P stands for pneumonia. SMOP. So what are the things you have to know about the strep pneumo? Gram-positive cocci, lancet-shaped diplococci, encapsulated, optogen sensitive with the SMOP. Okay, if you are still remember, you want to know, it is showing a IgA proteases playing a role here. IgA proteases playing a role here. This is another one they may expect you to see it in the strep pneumo. This is the another one they may expect you to see it in the strep pneumo. Okay. Next is the optogen resistant, which is your viridin streptococci. Whenever you see the viridin streptococci, immediately think about the 2 things. Dental, heart. Immediately think about the 2 things, which is a dental and a heart. And it is a optogen resistance, you already know. So dental, it is caused by streptococcus mutans and mitis. Okay. So whenever you see the streptococci, what are the things you have to remember? One is your teeth, another one is your heart. One is your teeth, another one is your heart. Because in that scenario, that time when I was making this note, there was only a viridin streptococci. Nowadays, they are asking us subtypes of your streptococci viridins too. So that's why I am writing this. So whenever you see the, teeth and in the heart, the dental ones are carried out by, dental caries are done by, are caused by strep mutans and mitis. Mutans and strep mitis people. Okay, what are the 2 organisms which is causing a dental caries? Strep mutans and strep mitis. While in the case of your heart, it is a most common organism which is causing a subacute endocarditis. So acute bacterial endocarditis, it is a Staph aureus, yes or no? But subacute endocarditis, subacute infective endocarditis, then it is a subacute infective endocarditis, then it is a viridin streptococci. Among that viridin streptococci, if you're looking at the subtype, then strep sanguinis. Okay, strep sanguinis. Okay, strep sanguinis is causing the, what do we call it? Subacute infective endocarditis. Like sanguine is a blood in the Greek, right? Yes or no? In Latin, sanguinis means blood. So strep sanguinis means it is in the blood. So blood, heart. In fact, subacute infective endocarditis, you have to remember it. Okay, you have to remember it, which is the optogen resistant. Optogen resistant. Okay, so we have talked about the alpha hemolysis with the optogen sensitive and resistant. Sensitivity is strep pneumo, while resistance is your viridin streptococci. Resistance is your viridin streptococci. Speaking about the viridin streptococci, what are the things you have to remember? 2 things. One is your dental, another one is your heart. In the dental, it is caused by dental caries. Dental caries is caused by mutans and mitis. Subacute bacterial endocarditis is caused by Staph sanguinis. Staph sanguinis. Apart from that, it is normally present in. Sometimes they ask this as a question. So I'm writing this. It is normally present in oropharynx. Normally present in oropharynx. You have to remember that. Present in oropharynx, and drug of choice is your penicillin. Drug of choice is your penicillin. You have to remember that, people. In the case of your optogen resistant viridin streptococci. So strep pneumo, viridins, alpha hemolysis we have done. Now we are moving on to the beta hemolysis. Speaking about the beta hemolysis, which is a bacitracin sensitive and bacitracin resistance. Okay, bacitracin sensitive and bacitracin resistance. So bacitracin sensitive is group A streptococci and bacitracin resistance is group B streptococci. Group A streptococci is also known as strep pyogens. Streptococci pyogens, we have already studied that. And group B is streptococci agalacea. Strep agalacea. Strep agalacea. Okay, speaking about the gas, which is your gram positive with the catalase negative and beta hemolytic bacitracin sensitive one is your group A streptococci. So group A streptococci, we can able to say whenever you see that, you also know that the streptolizin O and S, among that streptolizin O comes under the category of which one, people? Streptolizin O comes under the category of disintegration of your cell membrane. Yes or no? Streptolizin O is a protein which disintegrates your cell membrane, that we have studied in your exotoxin category. Am I right or wrong? So what you can able to say in the case of your group A streptococci is, we can able to say there are 4 properties. One is your pyogenic, where you see the pharyngitis, cellulitis, impetigo and all. Toxigenic, where you see the scarlet fever, and necrotizing fasciitis, and apart from that, TSST, toxic shock syndrome, or TSS, toxic shock like syndrome, I rather say, TS like syndrome. And apart from that, immunologic, it may causes a rheumatic fever. Rheumatic fever or rheumatic heart disease, where you see the Jones criteria. Yes or no? Where you see the Jones criteria. So in the scarlet fever, you may see what is the characteristic lesion you may see it in the scarlet fever, people. But do you remember what is the characteristic lesion you may see it in the scarlet fever? That is your strawberry tongue. And sandpaper-like rash. Strawberry tongue and sandpaper-like rash. Okay, sandpaper-like rash. Okay, apart from that, you have a bacitracin resistant, which is your group B streptococci. So group B streptococci with the bacitracin resistance and beta hemolytic, which is streptococci agalacea, mostly colonizes in your vaginal mucosa, and it can able to produce 2 important things. One is your meningitis and another one is your pneumonia in the children. And activation of it produces the CAMP factor, not cyclic AMP. It is a CAMP factor. Okay, remember that it is not a cyclic AMP. It is a CAMP factor, and it shows a Hippurate test positive, and PYR negative. So normally colonizes in vagina, vaginal colonies you may see. Meningitis and pneumonia in children you may see. Okay, don't drive on, I'll write it here. Meningitis and pneumonia in children you may see. Meningitis and pneumonia you may see in children. And activation of CAMP factor or production of CAMP factor and Hippurate test positive and PYR negative. Hippurate test positive and PYR negative, which is your group B streptococci or Streptococcus agalacea. Okay, Streptococcus agalacea. Okay. And apart from that, gamma hemolysis, which is grows in 6.5% NaCl and does not grows in the 6.5% NaCl, where we studied that in the type of media. I've told you strep bovis will not grow in the 6.5% NaCl, while enterococcus grows in the 6.5% NaCl. Yes or no? So speaking about the Enterococcus species, what are the things you have to know? It will produces the, it will hydrolyzes the bile. So it is technically present in your colon. Okay, it is technically present in colon, and it forms a esculane with a black complex. Very, 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 very important. It forms a esculane with the black complex. It can produce as a UTI, biliary tract infection, and a subacute endocarditis, and it can also produces it can also be PYR positive. So gram positive cocci with a catalase negative gamma hemolysis grows in 6.5% NaCl, hydrolyzes bile, normally present in colon, esculin with a black complex, produces UTI and biliary tract infection and subacute endocarditis. All of them is produced by your Enterococcus species. Okay, could be of Enterococcus faecalis or Enterococcus specium. Okay, any of these two things you have to remember. Apart from that, strep bovis, which is seen in the normally in the gut, so in the colon, so it is associated with the colon cancer. Sometimes it can produce as again subacute endocarditis and bacteremia. Okay, subacute endocarditis and bacteremia. So this is a gamma hemolysis, people. This is all about the gram positive cocci. And speaking about the gram negative cocci, we are having two things in the gram negative cocci. One is your Neisseria species, Neisseria meningitis and Neisseria gonorrhea, which is a gram negative diplococci, which uses the maltose. If it is a maltose utilization, positive is seen in a meningitis, that is a maltose fermentation is seen in meningitis, while maltose fermentation is not seen in the gonococci. Okay, maltose fermentation is seen in meningitis, maltose fermentation is not seen in gonococcus or Neisseria gonorrhea. Okay, and you may see the polysaccharide capsule, Waterhouse-Friderichsen syndrome. Very, 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 very important. Okay, meningococcus produce Waterhouse-Friderichsen syndrome, and it shows a beta lactase activity. And the drug of choice is ceftriaxone or cefoxamine. Ceftriaxone or cefotaxime. Okay, while here in gonococci, creamy purulent discharge, Thayer-Martin agar, Fitzhugh-Curtis syndrome, and apart from that, ceftriaxone is a drug of choice. Very, 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 very important. Okay, gram negative diplococci with a maltose fermentation is seen in Neisseria meningitis, while your maltose fermentation is not seen in Neisseria gonorrhea. So Neisseria species grows in the chocolate agar, and among the gonorrhea grows in the Thayer-Martin agar, while meningitis does not grow. While meningitis, what are the things you have to remember? It can cause Waterhouse-Friderichsen syndrome, polysaccharide capsule, and drug of choice is ceftriaxone or cefotaxime. Okay, gonorrhea, creamy purulent discharge, Thayer-Martin agar, Fitzhugh-Curtis syndrome, drug of choice is ceftriaxone. So this is all about the cocci, people. This is all about the cocci you have to remember. So most of the point which has been covered up over here regarding the cocci. So you have to remember that there are few image-based questions in the cocci where the cultural media and organism they may give you. So this is a like a pinpoint colonies of your Streptococcus pyogenes. You have to know that. And strep viridans, where you see the oval-shaped gram-positive cocci in the chains. And apart from that, strep pneumo, where you see the carom coin appearance. And you have the Enterococcus species, where you see the spectacle-like appearance. And apart from that, these are the important ones you have to know in terms of your colonies. So golden yellow colonies in the Staph aureus, mannitol salt agar, pink colonies in McConkey agar, strep pyogenes, pinpoint colonies. and strep viridans, which is a gram-positive cocci in chain, strep pneumoniae, which is a carom-coi in appearance, enterococcus, where you see the spectacle-like appearance, So far we have covered about the gram-positive cocci. So have a look and read it down for 5 minutes. So shall we revise it, people? What are the things should come into your mind whenever we talk about the staph aureus? Protein A, beta hemolytic, golden yellow colonies in the mannitol salt agar, TSST1 can produce toxic shock syndrome, exfoliative toxin can produce Caldwell syndrome, most common organism causing acute food poisoning, acute osteomyelitis, acute endocarditis. Drug of choices, penicillin. For MRSA, methicillin resistant staph aureus, vancomycin. For VRSA, linezolid or quinipristin. For novobias sensitive and resistance, epidermiditis and saprophyticus, epidermiditis, subacute endocarditis, and IV drug abuser, prosthetic devices are normally present in the skin, which is present as a clusters, and it is a urease positive. Well, staph saprophyticus, UTI in the sexually active female. Okay. Then you have this catalase negative. So catalase negative 3, alpha, beta, gamma hemolysis. Alpha hemolysis, optogen sensitive, resistant. Optogen sensitive is strep pneumo, where you see lancet-shaped diplococci, most commonly present in lancet-shaped diplococci, most commonly associated with SMOP, which is your sinusitis, meningitis, otitis media, and you have the pneumonia. What type of pneumonia? Rusty sputum pneumonia in over 60 years as splenectomy patient. Apart from that, it is encapsulated and it shows a IgA protease activity. While optogen resistance or viridin streptococci normally present in your oropharynx, dental caries is caused by mutants and mites, while subacute infective endocarditis is caused by strep sanguinis. Okay, then you have this, what do we call it? Beta hemolysis, bacitracin sensitive and resistant. Bacitracin sensitive, gas, streptococci pyogens, streptolysin O and S, pyogenic effect, toxigenic effects such as scarlet fever and necrotizing fasciitis, where you may see the strawberry tongue and sandpaper-like rash in the scarlet fever. Apart from that, it may show the rheumatic fever. Okay, then you have the bacitracin resistant, which is a group B streptococci or Agalaceae, normally present in vagina, meningitis and pneumonia in children. Epurate positive produces CAMP factor and PYR inhibition. Very important MCQ is this CAMP factor production. Okay, it is not a CAMP. It is a CAMP factor production. Then you have a gamma hemolysis, grows in 6.5% NaCl, which is your enterococcus species, where you see the hydrolysis of a bile, normally present in colon, esculin with the black pigment, and UTA. And do not grow strep bovis associated with the colon cancer because it is also present in the colon. Then gram negative, mostly a diplococci, Neisseria. Maltose fermenting one is your Neisseria meningitis. Maltose non-fermenting one is your Neisseria gonorrhea. Neisseria meningitis, Waterhouse-Friderichsen syndrome, drug of choice is ceftriaxone, and it may shows the polysaccharide capsule. While Neisseria gonorrhea, creamy pueril and discharge, Thayer-Martin agar, Fitzhugh-Curtis syndrome, drug of choice is ceftriaxone. It can produce as a STD. And a pelvic inflammatory disease also. You have to remember that. Okay. So far we have done the gram positive and gram negative cocci. So take a break of 10 minutes and come back by 4-5. We will do the gram positive and gram negative rods. And once we finish it, our bacteriology will be ending. And then we move on to the virology and then mycology and parasitology. Okay. So that we can able to finish our microbiology maximum by 5:30 we can able to finish it. Okay, take a break of 10 minutes and come back after 10 minutes so that we can produce this. We can able to proceed with that. Okay, have a nice day. So very good evening. So if you could hear my voice and see the screen properly, type yes on the chat box, people. So we are resuming our session 2. If you could hear my voice and see the screen properly, type yes on the chat box. Now, the next area of interest we are going to talk about, is your rods, people, gram positive as well as gram negative rods. So we will talk about the gram positive and the gram negative rods. So the first one is your gram positive rods. We can able to talk about it. So speaking about the gram positive rods, it could be of a spore forming or non-spore forming. It could be of a spore forming or non-spore forming one. So speaking about the spore forming one, it could be further classified into aerobic and anaerobic. It could be further classified into aerobic as well as anaerobic. And speaking about the aerobic and anaerobic, it is further classified into motile and non-motile people. It is further classified into motiles and non-motile. Speaking about the motile one, both are the aerobic spore forming gram positive rod as your bacillus species. Aerobic spore forming gram positive rod is your bacillus species. So speaking about the bacillus species, among that bacillus species, we are going to talk about the two important one. One is your Bacillus cereus, another one is your Bacillus anthracis. One is your Bacillus cereus and another one is your Bacillus anthracis. So speaking about the Bacillus cereus, which is your motile one, which is your motile spore forming gram positive rod, which is your motile spore forming aerobic gram positive rod. This Bacillus cereus produces a heat labile toxin. This Bacillus cereus will produce the heat labile toxin. And speaking of a heat labile toxin, which can able to increase your cyclic AMP and associated with food poisoning. Okay, associated with food poisoning. As we talked about already, that we have talked about in our staff RES. Yes or no? We have talked about that in our staff RES. So speaking about the staph aureus, what are the things we have talked about? It is the most common cause of acute food poisoning. Yes or no? But what would be the difference? How it is differing from the Bacillus cereus? Differing from reheated rice syndrome. So they may give you the history of fried rice and the initiation of nausea and vomiting within 1 to 5 hours. Then it is a Bacillus toxin, which is a hematic toxin defect. If it is a diarrheal type, it should be lasting from 8 to 18 hours. Then apart from that, you have a Bacillus anthracis. So speaking about the Bacillus anthracis, it is a gram-positive spore-forming rod which produces an anthrax toxin, and it is a capsulated one, and colony shows halo of projection or medusa head appearance, where we used to see the medusa head appearance is seen in Bacillus anthracis. So here we may have this Bacillus anthracis. So here you may have the Bacillus anthracis bamboo stick appearance, and you may have the string of pearl appearance, and you may also see the Bacillus appearance. Here you have the Bacillus cereus, crenated colonies with fimbriated colonies. Crenated colonies are fimbriated colonies you are having. So speaking about that gram positive spore forming aerobic species, motile one is cereus, non-motile one is anthracis. So cereus we have talked about it, anthracis we have talked about it. So speaking about the anthracis, it is forming a what type of appearance? Medusa head appearance, and apart from that string of pearl appearance, apart from that bamboo stick appearance, or the three appearances, you may see it. Apart from that, the anthracis may be producing the anthrax, and that anthrax could be of pulmonary anthrax or cutaneous anthrax. Pulmonary anthrax or cutaneous anthrax. Speaking about the cutaneous anthrax, there will be a painless papule which is surrounded by your vesicles. Okay, painless papule which is surrounded by the vesicles. Painless papules which is surrounded by your vesicles. Which is surrounded by vesicles. Which is surrounded by vesicles, where it may form the painless necrosis like a black eschar. It may progress into the bacteremia, and that, but that was very uncommon. Okay, mostly they will be seeing a painless papule. They may progress into black color eschar one. Apart from that, pulmonary anthrax, where whenever you see the inhalation of the spores, then you may see there is a fever with the pulmonary hemorrhage on the mediastinum and a shock. Okay, all this can be progressed in a very fast pattern, and chest X-ray shows widened mediastinum. That's the clue if they was giving you for the anthrax as a case-based one. Okay, widened mediastinum is a classical clue. Widened mediastinum is a classical clue for Bacillus anthracis ulcerta disease, which is also known as the pulmonary anthrax, where you may see the fever, pulmonary hemorrhage, mediastinitis, and shock. Okay, that is so called as ulcerta's disease. So it contains two factors: lethal factor, edema factor, cutaneous and pulmonary. Pulmonary, pneumonia, and ulcerta's disease, where you see the widened mediastinum. And what are the types of appearance you may expect to see it in the anthrax? Medusa head appearance, and you may see the bamboo stick appearance, and you may see the sting of pearl appearance, people. You may see the sting of pearl appearance. All of them will be seen in this case of your Bacillus anthracis. Now, speaking about that anaerobic, which is your motile and non-motile. Speaking about that anaerobic, which is your motile and non-motile. Anaerobic is your Clostridium species. Anaerobic is your Clostridium species. So speaking about the Clostridium species, there are four things you have to know about the Clostridium species. One is your tetani, botulinum, difficile, and perfringens. The tetani, botulinum, difficile, and perfringens. So speaking about that Clostridium tetani, it can able to produce a tetanospasmin, which is an exotoxin, which can inhibit the GABA, and it can able to produce the spastic paralysis. It can able to produce the spastic paralysis. And to prevent it, what is the vaccine we use? TT is the vaccine we use. Tetanus toxoid is the vaccine we use. So what are the things in the Clostridium tetani? Tetanospasmin, inhibition of GABA, where you see the spastic paralysis. That is your trismus or rhizus sardonicus. I rather write it the clinical features of a spastic paralysis in various areas. First one is your lockjaw, that is your trismus. And you have this rhizus sardonicus. Rhizus sardonicus, which is your spasm of your spinal muscles. And apart from that, you have, raised eyebrows and your extensions. And apart from that, your opisthotonos. Opisthotonos are the features of your Clostridium tetani, which is the spastic paralysis results in various areas. Okay, so tetanospasm, inhibition of GABA, spastic paralysis, TT is a vaccine. So spastic paralysis, trismus, or maybe a rhizus sardonicus and opisthotonos. Okay, opisthotonos. All of these things are the features of your Clostridium tetani. Then you have a botulinum, inhibition of your acetylcholine release at the neuromuscular junction is so-called as botulism. So speaking about the botulism, it can also produce a flaccid paralysis, and mostly associated with the canned foods. Mostly associated with the canned foods like in a honey and other canned foods, it can result in, and it can produce a botulism. What is a botulism? I used to remember it with the same like a pellagra. We are having a 4 Ds for botulism. We are having a 4 Ds for botulism. Let me erase it. Here. What are the 4 Ds of botulism? What are the 4 Ds of botulism? 4 Ds of botulism. The 4 Ds of botulism are diplopia, dysarthria, dysphagia and dyspnea. Dysphagia and dyspnea. Dysphagia and dyspnea. Okay, are the 4 Ds of your botulism. Okay, are the 4 Ds of your botulism associated with the canned foods like like a juice, honey, and all of them. They can produce a flaccid paralysis. They can produce a flaccid paralysis. Apart from that, we use like a focal Botox injections for your muscle spasms and cosmetic reduction of your facial wrinkles. We can use a botulism. And apart from that, you may use this for the focal dystonia, achalasia. We can use a botulism injection. All of these things are the clinical usage of your Clostridium botulinum toxin. Okay, Botox injections uses. Then apart from that, Clostridium difficile, which is your hospital acquired one, and it produces a 2 toxin. One is a toxin A, which is an enterotoxin, and a toxin B, which is your cytotoxin. Okay, toxin A, which is an enterotoxin, and a toxin B, which is a cytotoxin. And mostly it is associated with the pseudomembranous colitis. Very, 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 very important. Pseudomembranous colitis, and it produces yellow plaques. Mostly diagnosed by the PCR, but anything can be used. So technically, what are the things you have to know? The difficile is for diarrhea, which is a pseudomembranous colitis. It produces yellow plaques. It contains a 2 toxin, enterotoxin and cytotoxin, and it can able to, the treatment is metronidazole or oral vancomycin. We can use. Apart from that, Clostridium perfringens, phospholipase C activation, and mostly associated with the undercooked food, gas gangrene, where you may form the yellow yolk agar stomy fermentation. Egg yolk agar stomy fermentation. So this is the Clostridium anaerobic Clostridium motile 1. 3. What are they? Tetani, botulism, and difficile. Tetani, botulism, and difficile. So what are the tetani 1? Tetani 1 is seen in tetanospasmin, inhibition of GABA, spastic paralysis, and it is tetanus toxoid is a vaccine. So what type of spastic paralysis? Trismus, Rhizus sardonicus, and opisthotonos. And opisthotonos are the keywords they may give you. Apart from the Clostridium botulinum, flaccid paralysis, inhibition of acetylcholine release, and you may see it in the canned food poisoning, and you may see the botulism. Speaking about the botulism, what are the 4 Ds of botulism? Which is your diplopia, dysarthria, dysphagia, and dyspnea. Diplopia, dysarthria, dysphagia, and dyspnea. Apart from that, local Botox injection can be used for the treatment of your cosmetic reduction of your facial wrinkles, and it may be achalasia cardia, muscular spasm, and like a focal dystonia. We can use a Botox injections. Then Clostridium difficile, pseudomembranous colitis, hospital acquired yellow plaque. Well, Clostridium perfringens, which is a non-motile one, phospholipase C, and gas gangrene with the egg yolk agar and the stormy fermentation. And stormy fermentation are the things you have to remember. So these are the spore-forming bacteria, people. Spore-forming aerobic is Bacillus, and spore-forming anaerobic is Clostridium. Spore-forming anaerobic is Clostridium. Now, apart from that, we are having this non-spore-forming one. Speaking about the non-spore-forming aerobic, we are having an Actinomyces israeli. So speaking about that Actinomyces species, the very, 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 very important species in the Actinomyces species is your Actinomyces israeli. Among that, you have to remember, in the case of your Actinomyces, it can produce a sulfur granules. Associated with the IUD associated infections. IUD associated infection. Sorry, it was written as a IVD. It's a IUD, intrauterine. IUD associated infection, and it is a non-acid fast bacilli. It is a non-acid fast bacilli. Apart from that, it is a branching rods. Apart from that, it is a branching rods. Sulfur granules associated with the IUD, infections associated with the IUDs and PID. Apart from that, it is a branching rods. Apart from that, it is a branching rods. Treatment of choice is penicillin. So this is the one you have to remember in terms of your actinomyces. In terms of your actinomyces Israeli. Okay, actinomyces Israeli. Then you have this anaerobic motile and non-motile. Listeria, tumbling motility. Listeria is associated with the tumbling motility. Very, 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 very important MCQ. Meningitis and renal transplant. Apart from that, you have a non-motile nocardia aspergillosis, so which is a urease positive and it can produce as a mycetema. Urease positive, and apart from that, it can produce as a mycetema. Then you have the Corynebacterium diphtheriae. Very, 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 very important. In my lifetime, I had seen a one Corynebacterium diphtheriae. Due to the non-vaccination, we have seen the typical characteristic Chinese letter pattern you may see. Typical characteristic Chinese letter pattern you may see. Apart from that, you may see the volutin granules in the Loeffler's medium and black colonies in terylite agar. Okay, volutin granules in the case of your Loeffler's medium and black colonies in the case of your terylite agar. Apart from that, myocarditis, and it will show the recurrent laryngeal nerve palsy. It will show the recurrent laryngeal nerve palsy. Apart from that, pseudomembranous pharyngitis you may see, and lymphadenopathy you may see, arrhythmias you may see. All of the things you may see it in the Corynebacterium diphtheriae. So how do you remember the Corynebacterium diphtheriae? I used to remember with the mnemonic of A, B, C, D, E. A, B, C, D, E, F, G. Okay, A, B, C, D, E, F, G. So what is the A stands for? A stands for ADP ribosylation. ADP ribosylation. B stands for beta prophage. Beta prophage. And C stands for Chinese letter pattern. Beta prophage and black colonies also. Black colonies. And the C stands for Chinese letter pattern. Chinese letter pattern. D stands for diphtheria toxin. Diphtheria toxin, which inhibits elongation factor 2. EF stands for elongation factor 2. And G stands for it can produce a blue-red granules. Granules of blue and red. Blue-red granules. Okay, these are the one I have to remember. These are the one I used to remember for the Corynebacterium diphtheria. A, B, C, D, E, F, G. So ADP ribosylation, beta prophage and black colonies, Chinese letter pattern, diphtheria toxin, which inhibits elongation factor 2 and produces red and white granules, and red and blue granules. Apart from that, you may see a volutin granules, which is in the Loeffler's medium, and black colonies in the terylite agar. Okay, black colonies in the terylite agar. So these are the things you may need to know. Then you have this gram-negative one. So speaking about the gram-negative, aerobic, anaerobic, and the spirochetes. So speaking about that, we have finished the gram-positive one. Spore forming, non-spore forming. Along with that, everything we have done, people. Everything we have done with the spore forming and non-spore forming aerobes and anaerobes. Next is a gram-negative one, aerobes and anaerobes and spirochetes. So speaking about the aerobes, first one is your Pseudomonas aeruginosa. First one is your Pseudomonas aeruginosa in the case of your gram-negative. Okay, first one is your Pseudomonas aeruginosa. Speaking about the Pseudomonas aeruginosa, it can produce grape-like odor. It can produce grape-like odor, and it can form a slim layer. It can form a slim layer, and exotoxin A, which inhibits elongation factor 2, pneumonia in CF patients, pneumonia in CF patients, osteomyelitis in drug addicts, and you may see the ecthyma gangrenosum, and you may see the ecthyma gangrenosum, grape-like odor, aerobic motile gram-negative rod, aerobic motile gram-negative rod, which produces grape-like odor, which is which produces exotoxin A, which can able to inactivate elongation factor 2, and it can produce two pigments, pyoverdin and pyocyanin. Two pigment can be produced. One is your pyoverdin and another one is your pyocyanin. Pyoverdin, pyocyanin, pyocyanin, which can involve in the free radical metabolism. Okay, free radical removal. Okay, which can be present in the free radical removal. Okay, this is all about your pseudomonas. What are they? Grape-like odor, gram-negative motile rod, along with the aerobic and non-lactose fermentating grape-like odor, which forms a slim layer, and along with that, it can produce exotoxin A, which inhibits elongation factor 2, and pneumonia in CF patients, and osteomyelitis in drug abusers, and it can produce a ecthyma gangrenosum. Okay, ecthyma gangrenosum, which is typically a Pseudomonas bacteremia, which is seen in the immunocompromised individual. Okay, rapidly progressing type ecthyma gangrenosum is seen in immunocompromised individual. You have to remember that. Okay, then Bordetella pertussis, heme agglutinin or pertussis toxin, Bordet Gengau medium, and apart from that, okay, let me put up here, heme agglutinin or pertussis toxin, Bordet Gengau medium, and Reagan-Lewis agar, and it can produce whooping cough. It can produce whooping cough, which is a what type of cough it is? 100-day cough is so called as whooping cough, which can Bordetella pertussis is a pertussis toxin which can increases or suppresses the cyclic AMP and thereby producing a cytotoxic one. Apart from that, it can produce a coryza and it can produce a chronic cough. Then you have a Klebsiella. Speaking about the Klebsiella, Friedlander bacillus. Okay, Friedlander pneumonia, it may cause Klebsiella. So Klebsiella is an aspirational pneumonia most commonly seen in the Klebsiella. Current jelly sputum, technically current jelly sputum, Klebsiella pneumonia, abscess in the lung and liver, mostly associated with alcoholics and diabetes. That is the exact scenario you may see it in the Klebsiella people. Alcoholic, diabetes, current jelly sputum, which should be either a bloody or it could be a mucus, but it will be very, very thicky, like when you are doing a suction in that patients, we used to get it like a thick and purulent like one, which we had never seen it in the normal suction of the patient, where you see the current jelly sputum. That's the typical current jelly sputum. Mostly old age people who is undergoing a post-surgery and a nocosomial and who was a diabetic. That is a common type where you see the, like aspiration pneumonia, because these patients will have a higher chances of a post-surgical aspiration. So in that scenario, whenever you see the current jelly sputum, typically it is due to the Klebsiella pneumonia, which is a Friedlander pneumonia. Okay, you have to remember, but mostly associated with the multi-drug resistance. Sometimes it may be like, what do we call it? Novobiocin resistance, it may be showing. Sometimes most of the drug will be resistant, except the ciprofloxacin, or sometimes it may be due to some other drugs, or any drug. Okay, mostly it is associated with the multi-drug resistance people, I rather say. Next is anaerobes, which is a bacteroids, modified lipopolysaccharides, modified LPS, and Vincent's angina, very, 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 very important. Bacteroids produce Vincent's angina. And apart from that, it is associated with the post-traumatic infection or chronic disease infection. Bacteroides is mostly associated with the post-traumatic or chronic disease infections. Okay, then you have a spirochetes. Speaking about the spirochetes, we are having a Treponema pallidum, syphilis, where it shows the FTA ABS test positive, VDRL and RPR screening test. Primary, you see the painless infection. Secondary, rash. Third, tertiary, gumma formation, Hutchinson teeth, and Romberg sign, Charcot joint, and Argyll-Robertson pupil or prostitute's pupil. Argyll-Robertson pupil or prostitute's pupil, you may see it in the tertiary syphilis. So painless infections and ulcers, primary. Rashes, secondary. Gumma formation, Hutchinson teeth, Romberg sign positive, Charcot joint, Argyll-Robertson pupil. Those are all the characteristic features of tertiary syphilis. Drug of choices, penicillin G. Okay, drug of choices, penicillin G in a short term, or if you want to give a single dose, then you can go for the benzathine penicillin. Okay, then Borrelia burgdorferi, Lyme's disease, and Borrelia recurrentis, relapsing fever. Burgdorferi, you may see it in the Lyme's disease where you see the target lesion, and Borrelia recurrentis, you may see the relapsing fever. You may see the relapsing fever in the case of your this one. What do we call it in the case of your Borrelia recurrentis? Okay, fine. Then apart from that, what are the things you have to know? The exact lesion is so called as bullseye configuration. Okay, we used to get the erythema migrans in the form of bullseye configuration. Because one time they asked us a picture-based question. Bullseye configuration, I rather write. Bullseye configuration or target lesions. Sometimes the target lesions has been misinterpreted. So that's why I am using a bullseye configuration. Okay, bullseye configuration. Then you have the leptospira, where you see it in the contaminated water, meningitis, and associated with the Wales disease, people. And associated with the Wales disease. This is important. This is important in the case of your leptospira. Any contaminated water with the rat urine, most commonly, any post-flood, the first thing you have to give it prevent is your, leptospirosis, and it is associated with the Wales disease. It is associated with the Wales disease. You have to remember that. You have to remember that. Okay. Apart from that, very rarely, but sometimes they may ask you like, what is a Wales disease, which you see the multiple organ dysfunctions like a jaundice, azotemia, and a fever, hemorrhage, and anemia are the features of your Wales disease, mostly associated with the animal urine, water contamination with the animal urine like rodents, especially the rats. Leptospirosis, we may see it in the lot of the people. Okay, when you're going for the practice, especially in the southern states of your Andhra Pradesh and your southern part of your Telangana, you may see lot of leptospirosis infection. Okay, especially from the village side, you have to know that. Okay, anyway, next is your facultative anaerobes, where H influenza, where you may see the Quillen's test positive. H influenza is associated with the Quillen positive, otitis media, acute epiglottis, and meningitis in 1 to 2 year old. Then you have a Vibrio cholerae, which is a comma-shaped one, rice water diarrhea, increase in cyclic AMP, transport medium is Cary Blair and Venkatraman Ramakrishnan medium. Okay, then E. coli, ETEZ can produce traveler's diarrhea, EAEZ can produce dysentery, EPEC-EZ is a pediatric diarrhea, EHEC is O157H7 type, which can process hemolytic uremic syndrome. Yesterday we have studied in the pathology, systemic pathology, we have talked about the hemolytic uremic syndrome and the platelet disorder. Yes or no? Any patient with the, you see the hemoglobin drop with the platelet drop along with the renal parameters altered, then that is a triad of your HUS. Then that is the triad of your hemolytic uremic syndrome, where you have to see the hemorrhagic E. coli infection, that too with the O157H7 subtype. O157H7 serotype. You may see that infection in that patient. Then you have a Salmonella. Salmonella produce endotoxin and a VA capsule. And you may see the raw spots. Very, 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 very important. Raw spots is associated with the Salmonella. Raw spots is associated with the Salmonella. And apart from that, mostly it can produce as a, it can passes through the hematogenous spread. So you may see the Widal test positive. You may see the Widal test positive, and it can produce as a typhoid fever where you see the raw spots on the body, especially on the abdomen. And apart from that, it can drug of choices fluoroquinolone. Drug of choices fluoroquinolone. So what are the things you need to know in the case of Salmonella? Endotoxin and VA capsule are the virulent factors, and apart from that, it can produce as a raw spots and typhoid fever. And apart from that, it is a Widal test. It shows positive for Widal test. Drug of choices fluoroquinolone. Drug of choices fluoroquinolone. Then you have a Shigella, where you have to remember it like a 4 F's: fingers, flies, food, and feces. Fingers, flies, food, and feces. So it can produce as a bloody diarrhea, and it shows a PMN infiltration. And apart from that, Shiga toxin is an enterotoxin. Shiga toxin is an enterotoxin we have done. Yes or no? What is the Shiga toxin does? Shiga toxin and Shiga-like toxin we have studied in exotoxins. What are that? What are that Shiga toxin, which is an enterotoxin, which is acting on the 60S ribosomes? Yes or no? And inhibits the protein synthesis. Acts on 60S ribosome and inhibits protein synthesis. Am I right or wrong? Protein synthesis. Okay. Then you have to remember about the PMN infiltration. So 4 F's: fingers, flies, food, and feces, the transmission occurs. And apart from that, bloody diarrhea, PMN infiltration, and Shiga toxin, which act on 60S ribosomes. Okay, Shiga toxin, which act on 60S ribosomes. And apart from that, you have the protease infection, non-lactose fermentation, H2S producing one, swarming motility, and protease is associated with the stagon calculi, triple phosphate calculi or stagon calculi. It is associated with the protease infection. Then you have a Yersinia pestis, safety pin appearance, and it is associated with the plague. It may be bubonic or pneumonic. Drug of choices, aminoglycosides. Drug of choices, aminoglycosides. With this, we are completing the important species of your gram-positive and gram-negative. Important species of your gram-positive and gram-negative. Here we have done Clostridium tetani, ground glass appearance, Clostridium perfringens, hemolytic colony, inverted fir tree appearance of your, Bacillus anthracis. And apart from that, you may see the Clostridium difficile's yellow colony, botulinum, egg yolk agar, and a diphtheria, Chinese letter pattern. You see this Chinese letter pattern. And it is a listeria, gray-green colonies with the black precipitate, nocardia, bearded branch filaments, actinomyces, spidery colonies, Neisseria meningitis, semicircular diplococcus with flat opposing ends, Neisseria gonorrhea, kidney shape, which is a gram-negative diplococci, E. coli, rod shape, 1 gram-negative rod, and Salmonella typhi, jet black, very, 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 very important, jet black metallic sheen in XLD agar, and Pseudomonas aeruginosa, greenish yellow colonies on nutrient agar. Protease species, dying phenomena. You have to remember all of these images which is related to the bacteria. All of these images which is related to the bacteria, you have to remember. And all of them are pretty important images that you should not miss, people. So this flow charts with the additional information and this image-based question will mark you about the most of the questions here, people, in the bacteriology. So there may be some other additional things. There may be some other additional points. You may see it and you're reading your notes. Add it on your notes, people. Add it on your notes and then make this flowchart a very easy one and get a bird eye view. Okay. First of all, try to get the bird eye view so that you can able to answer most of the questions, people. You can able to answer most of the question. Okay, clear about that? Shall we move on to the next one? Shall we move on to the virology? Shall we move on to the virology, people? Okay, speaking about the virology, the first category of viruses we are going to see is your herpes virus. The first category of viruses we are going to see is your herpes virus family. So speaking about the herpes virus, we classify the herpes virus from 1 to 8 people. 1 to 8. HHV1 human herpes virus 1, 2, 3, 4, 5, 6, 7, and 8. 5, 6, 7, and 8. Now speaking about that 1 to 8, HHV1 and 2 will form the herpes simplex virus. Will come from herpes simplex virus, and HHV3 is varicella zoster, HHV4 is Epstein-Barr, and HHV5 is CMV. HHV6 is B cell lymphotrophic virus, and HHV7 is RK virus. 8 is radenovirus. Okay, 8 is radenovirus. Okay, now expanding each and everything and know the highlights, that is more than important for the herpes family. Herpes viridae is one of the classical thing you may expect to see in the FMGE. One of the very, very important MCQ perspective. It is very, 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 very important. So first one, HHV1 and 2, herpes simplex virus, where it forms a Cowdery type A bodies. What type of bodies it may form? Cowdery type A bodies it may form. Then you have a type 1 and type 2. HHV type 1 is associated with the trigeminal ganglia. So you may see the oral infection. You may see the oral infection. While in the case of a type 2, you may see the genital infection. Okay, you may see the genital infection. So depending upon what type of a what type of rash is associated with what type of infection, you can able to come to the conclusion that this is this type. Okay, herpes simplex, it is a oral infection type 1, and genital infection type 2. And a Cowdery type A bodies will be produced, and it may produce a multinucleated giant cells on Zank smear. Another important MCQ. Cowdery type A is a formation of multinucleated giant cells on Zank smear. Multinucleated giant cells on Zank smear. What are the clinical features? Fever, blisters, herpetic whitlow, eczema, and Kaposi's varicella of eruptions, and gingivostomatitis will be there. And it can transfer from mother to baby through the normal delivery. If you're doing a vaginal labor, then it can transfer infections from mother to baby. So HSV is very, very important. Type 1, trigeminal ganglia, oral infection. Well, most common site is a buccal mucosa. Type 2 is sacral ganglia, where you see the genital infection. And then you have a Cowdery type A, formation of multinucleated giant cells, which is seen in the Zank smear. And it can transfer from mother to baby through vaginal labor. It can transfer from mother to baby through vaginal labor. Then you have varicella zoster virus. Incubation period is 10 to 21 days. Centripetal type of rash, and it shows positive for OKA strain. And differential diagnosis, which is with the varicella zoster virus PCR, and the complications are pneumonia and encephalitis. Okay, latent infection of your varicella is shingles and Ramsay-Hunt syndrome whenever it shows the involvement of your facial nerve. Ramsay-Hunt syndrome whenever it shows the involvement of your facial nerve. So varicella zoster, what are the things you have to know? Incubation period is 10 to 21. Centripetal type of rash, OKA strain positive, and latent infection shows shingles and Ramsay-Hunt syndrome when it involves the facial nerve. Okay, Ramsay-Hunt syndrome when it involves in the facial nerve. And then complications such as pneumonia and encephalitis. Pneumonia and encephalitis. Then you have a EBV, which is a kissing disease. Incubation period is 30 to 50 days. Major target is B lymphocyte, which is a CD21. And the immortalization of the virus can progress into malignancy. So since it is a malignancy, EBV is a viral marker for Burkitt's lymphoma, Hodgkin's, T or NK cell lymphoma, nasopharyngeal carcinoma, anaplastic gastric cell carcinoma. Among that, The very important is EBV is associated with the Burkitt's and Hodgkin's lymphoma. Burkitt's and Hodgkin's lymphoma. Very important MCQ. Kissing disease and Burkitt's lymphoma and Hodgkin's lymphoma tumor marker is your EBV. Then you have a CMV, which is the largest virus, Owli inclusion bodies, and receptor for Ig, Fc portion, and clinical features include microcephaly. Owli inclusion bodies you may see. Owli inclusion bodies you may see, and treatment is ganciclovir. Ganciclovir and foscarnet is a treatment. HHV6, which is like a virus for CD46, and it causes a roseola infantum. And HHV7 is spread through the saliva. HHV8 is associated with the Kaposi sarcoma. That's why it is also known as Castleman disease or Kaposi sarcoma virus, or also known as Kaposi sarcoma virus. So herpes virus, HHV1 to 8, herpes simplex, varicella zoster, Epstein-Barr, CMV, human B-cell lymphotrophic virus, RK virus, and radiovirus. Simplex type 1, trigeminal ganglia, oral. Type 2, sacral ganglia, genital infection. Cowdery type A, formation of multinucleated giant cell, which shows a Zank smear. And VZV, which is an incubation period of 10 to 21 days. Centripetal type of rash, OKA strain, and complications such as pneumonia or encephalitis. Latent infection causes shingles, Ramsay-Hunt syndrome if it is involving the facial nerve. EBV, kissing disease, Burkitt's lymphoma, Hodgkin's lymphoma, TR-NK cell lymphoma. Apart from that, CMV, largest virus, Owli inclusion bodies, receptor of Ig, Fc portion, and treatment of choices, ganciclovir and foscarnet. HHV6, CD46, and roseola infantum. HHV8, Kaposi sarcoma virus, and Castleman disease. Okay, Castleman disease. This is all about the human herpes virus family, people. This is all about human herpes virus family. Then next important family is your hepatitis. Hepatitis and HIV, if you do those things, then we can able to finish most of your virology, important areas of your virology. Apart from that, other viruses are the minimal viruses. Okay. So hepatitis A, incubation periods of hepatitis A to E are important. A, 15 to 45 days, come from enterovirus 72. B, 45 to 180, hepadnavirus. C, 130 to 120, hepacivirus. D, 30 to 90, Briard's like 1. And E, 21 to 45, calcivirus. 21 to 45, calcivirus. Apart from that, A and E will transmit through the fecal oral transmission, while B and C is associated with the sexual transmission or IV transfusion. Okay, IV drug abuse. Apart from that, we need to know about the markers for hepatitis B, which is a very high yield one. So speaking about the markers for hepatitis B, one is your DAN particle, which is a complete hepatitis B with the all three antigen, and spherical particle, which is the most common one, which contains HPS-AG alone. So what is this antigen or serological markers in hepatitis B people, which is very important. Okay, which is very important. First one is antigens. We will talk about the antigen and then we will talk about the antibodies. Okay, first one is your anti-HPS-AG. First one is HPS-AG, which is a surface antigen. Surface antigen is present on the surface, hepatitis virus surface, where it indicates the hepatitis B infection. Hepatitis B infection. Then you have a core antigen. Core of the HPV, you may see the core antigen HBcAg. HBcAg. Apart from that, HBe enveloped the antigen. Okay, envelope the antigen, mostly secreted by your infected hepatocyte into the circulation. Okay, infected hepatocyte in the circulation. Whenever it is a mature HPV virion, then it is enveloped antigen will not be there. Okay, so whenever you see the enveloped antigen, that indicates active viral replication is happening and it is highly transmissible. And it is highly transmissible, then you may see the HBe antigen. So we are having a HBs, HBe, and you have this HBc antigen, core antigen. Yes or no? So among that, whenever you see the active HBV infection, whenever you see the active HBV infection, you see the surface antigen and enveloped antigen both. You see the surface antigen and enveloped antigen both. And whenever you see the acute infection, you see the IgM. Chronic infection, you will see the IgG. So what type of anti-HBC will be there? Active one. So acute one, HBsAg infection. Active replication, HBeAg. IgM, acute infection. And in window period, is there any active infection is happening in the window period? No. So none of the antigen will be there except anti-HBe will be seen along with the IgM. Then chronic HBV, which is a high infectivity, that means HBsAg, HBeAg will be there. But what's the difference here? Instead of IgM, it is a chronic, so IgG will be there. Then chronic with the low infectivity, no replication will be there, but the infection is persistent. So HBsAg and anti-HBe along with the IgE. Recovery, none of the antigen will be there, only antibodies will be there along with the IgG. And immunized individual, anti-HBsAg positive. Sorry, anti-HBsAg positive. That is an antibody against the HBsAg. Okay, that is antibodies against the HBsAg. One time we have the confusion back in our clinic, like one of the patients, whenever the dialysis patient comes, we do the serological markers for hepatitis B and C along with the HIV. Yes or no? Because so that we are doing a dialysis in that patient, we need to do it in the separate dialyzer. So we do the viral markers for the patient. And the lab people had called me and informed me that this patient is having a anti-HBs positive. Instead of saying anti-HBsAg positive, they said like HBsAg is positive. Okay, instead of saying anti-HBs positive, they said HBs anti is positive. HBs anti is positive. What is the HBs anti? Which is an antibody against the HBs anti is HBs antigen. Yes or no? Which indicates the hepatitis B infection. What is the anti-HBs? Which is an antibody against the HBsAg. In that patient, anti-HBs was positive. Anti-HBs positive indicates what, people? The patient is vaccinated against the hepatitis B. Yes or no? As per the scenario, patient is vaccinated against the hepatitis B. But I got a misinterpretation on the patient that he was positive for positive for the HBs anti. They didn't mention it as it's an antibody against the HBsAg. So we were doing two sets of dialysis in the separate dialyzer. We are trying to do that, but accidentally before initiating the dialysis, we checked the report. Once we checked the report, it was a HBs anti-HBs positive, not HBs antigen positive. So when you are saying, you have to be very, 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 very clear, because anti-HBs positive indicates patient is vaccinated. HBs anti-positive indicates the patient is having an acute infection. Patient is having an acute infection. So you have to be very, very clear, and you have to cross-check with the reports whenever you receive such a information. You should not make a mistake in the future, people. Okay. So next against that, so RNA virus. So next we are going to talk about the RNA virus. Speaking about the RNA virus, we have the first one as a picornaviridae. So the first one is polio virus. We are having a 3 types: type 1, type 2, type 3. And type 1 is associated with the P1, which is the most common one and causes an epidemic, while type 3 is P3, which is associated with the vaccine-associated paralytic polio, VAPP. And the first clinical case, one clinical case of your polio virus indicates thousands of clinical cases in children, and one clinical case in the in a community indicates there is a 75 subclinical case in the adult. 75 subclinical case in the adult, and we declared polio-free, people. Remember that, because when we were reading, when I was studying MBBS, most of the guest lecturer who comes from the America and the England, they still believe India is a house of polio. By the time we were studying, India was a polio-free for 5 years. Okay, India was a polio-free for 5 years, but still the people are thinking like polio viruses still exist in India. So make sure India is polio-free and we are doing an active surveillance against the polio. We are doing an active surveillance against the polio, and we are doing active surveillance against the malaria also. Okay. And this polio virus, we are doing a stool sample collection that could be done in the reverse cold chain, and it can be passed on to the red box through the National Institute of Virology. Where is it located, people? Where is the National Institute of Virology is located? Important PSM MCQ. It is located in Pune. It is located in Pune. We sent the stool sample to the Pune, that too with the early morning stool sample. That too with the early morning stool sample, two stool sample with the 24 hours apart. Whenever we see any symptomatic cases or any paralytic cases which is related, we suspect that which is related to the polio, immediately we send that sample to the National Institute of Virology through the reverse cold chain, where we put it in the red box. When the normal cold chain, we put it in the blue box, right? The vaccines were placed in the cold chain, which is put it in the blue box. While here, for a stool sample of your polio virus, we do it in the reverse cold chain. It is in the red box, and we send it to where? We send it to the National Institute of Virology, which is in Pune. You have to remember that. Okay. And mostly because it is affecting the anterior horn of your spinal cord, patient is experiencing the paralysis. Okay. So flaccid paralysis cases, whenever you see the AFP cases, acute flaccid paralysis, immediately collect the stool sample and send it there. Okay, to check for the polio. Okay. What happens if you're not treating it? If you're not treating it, then the ascending paralysis will happen. Paralysis of your limb, followed by paralysis of your abdominal muscles, followed by paralysis of your diaphragm. Once the diaphragm has been paralyzed, your respiration will not work, patient dies. Okay, once the diaphragm has been paralyzed, your respiration will not work, patient dies. That is the most common cause of a death in the polio patient. Most common cause of a death in the polio patient. Apart from that, the next virus is your Coxsackie virus, which can causes a hemorrhagic conjunctivitis and a hand, foot, and mouth disease. Very, 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 very important MCQ. Hand, foot, and mouth disease is associated with Coxsackie virus. Then you have an enterovirus, which is 70 and 72. 70 is for hemorrhagic conjunctivitis, and 72 is for hepatitis A viral infection. Enterovirus 72 is for hepatitis A viral infection. Then you have a Rioviridae, rotavirus, most common cause of diarrhea in children. Flaviviridae, HCV, yellow fever, dengue, West Nile virus, and arbovirus. Dengue, West Nile virus, and arbovirus, everything belongs to Flaviviridae family. And Togaviridae, it can gives rise to rubella. It can give rise to rubella. Then you have a HIV, type 1 and type 2. Type 1 is the most common HIV in the world, and type 2, which is we are having in India. Group M and subtype C is the most common variety, which is a single standard RNA virus. This is the structure of your HIV virus, people. This is the structure of your HIV virus. It contains a two proteins called a GP120 and GP41. Okay, GP41 and GP120 are the two outer proteins, and next to the outer protein you are having a capsid, nucleocapsid, which is the outer nucleocapsid and inner nucleocapsid. Outer and inner nucleocapsid are core of a nucleocapsid. Inner core surrounded by outer capsid, surrounded by outer membrane, which contains a membrane protein of GP120 and GP41 people. The outer nucleocapsid is also known as P18, while the inner one is P24. Okay. And apart from that, inner core contains viral protein associated with the RNA. Viral protein associated with RNA, while the outer, the enveloped one contains a lipid bilayer. Enveloped one contains a lipid bilayer. Okay. Then you have a three regions: GAG region, which encodes a viral code; POL region, which encodes a viral enzyme; ENV region, which encodes a viral envelope. Viral envelope. Now, speaking about that, most efficient transmission is through the blood, and apart from that, sexual, apart from that, maternal fetal transmission. Okay, diagnosis, screening is ELISA, confirmatory is Western blot. Now, this portion is 3-star rated topic, people. This portion is a 3-star rated topic, depending upon the number of CD count where you see the infection. CD count of less than 200 indicates pneumocystitis gyrovesi pneumonia. Pneumocystitis gyrovesi pneumonia. Less than 100 toxoplasmosis. Less than 50 CMV retinitis or Mycobacterium avium infection. What are the three things? Less than 200 pneumocystitis gyrovesi. Less than 100 toxoplasmosis. Less than 50 CMV retinitis along with the Mycobacterium avium. Mycobacterium avium. Apart from that, certain important things you have to remember. Apart from that, certain important things you have to remember. One is your virus and their shapes. Rabies, bullet-shaped virus, and tobacco mosaic, which is a rod-shaped one, and rota, wheel-shaped, pox, brick-shaped, astrovirus, star-shaped. And named inclusion bodies, again 5-star rated topic. So Bollinger or Borrell's body is seen in foulpox. Anderson-Pittenser bodies is seen in molluscum contagiosum. Negri bodies is seen in rabies. Guarneri bodies is seen in smallpox. Passion bodies is seen in variola. Taurus is seen in yellow fever. Lipschutz is seen in herpes and varicella. Cowdery type B is seen in adeno and poliovirus, while Cowdery type A is seen in human herpes virus 1 and 2. Human herpes virus 1 and 2. Here we have this. Okay, all the virology. Okay, so with this, we have completed the virology, people. With this, we have completed the virology. So next important portion here is your Mycobacterium. Mycobacterium tuberculosis, leprae, and marinum. Tuberculosis is associated with the fever, night sweat, weight loss, and cough. So any patient with the history of fever, night sweat, along with the weight loss and cough, then immediately think about a tuberculosis, and mostly it is due to the granuloma formation on the lungs, which is due to the TNF alpha positive. Okay, one of the efficient system which is working in the healthcare policy system which is working in India is your RNTCP. Okay, especially revised National Tuberculosis Control Program, which has been now changed into NTEP, National Tuberculosis Elimination Program, which was a very active one. Whenever you give a TB history, immediately the patient, the government people will come and take over the patient, and they get the information and they do the follow-up of a, like a DOTS regimen. You have to remember that. Okay, then you have the Mycobacterium leprae, tuberculoid, and lepromatous. Tuberculoid is a hairless skin plague where type 1 hypersensitive response. Lepromatous leprosy, you may see the leonine-like faces. Lepromatous leprosy, you may see the leonine-like faces, and Th2 helper cells response, you may see. Okay, and marinum, fish tank granuloma, you may see it in the Mycobacterium marinum. Then you have a mycology and parasitology. I just wrote the fungus name, and I just wrote the parasite's name and their important specific keyword. Okay, that's all I have written. So I don't want to insist more on the mycology and parasitology. If we insist, it will go on again further and further. Okay, so just what you need to know, and what are the important keywords if they are testing you with the case-based question, we have written it here. So one is your histoplasmosis, where you may see the palatal and the tongue ulcers, and you have this blastomycosis, granulomatous nodules, coccidioidomycosis, erythema multiforme or arthralgia, paracoccidioidomycosis, captain's wheel appearance, candidiasis, esophageal and oral thrush, very important, diaper rash, and endocarditis. Aspergillosis, septate hyphae. This is a characteristic feature, people. Whenever you see any lab report with a septate hyphae, immediately you may think like it is aspergillosis. You can able to initiate with the voriconazole or fluconazole, whichever is sensitive, you can able to initiate immediately. While exact contraindication is your aseptate hyphae, which is a mucormycosis. Okay, where exact contraindication is aseptate hyphae, which is a mucormycosis. So we had a patient once back in 2 years back, I guess. We had a patient with a simultaneous infection of your aspergillosis and mucormycosis. Aspergillosis and mucormycosis. So how does the report came to the patient? Can you able to see the difference here, people? Can you able to see the difference here? We have two types of report from the lab. It may come. The lab people never give you the report like it is aspergillosis, it is a mucormycosis. How they give you? With the fungal identification. Yes or no? There was a patient who came with the serious, like a serious rash all over his legs. Okay, serious rash all over his legs, and he is a post-COVID patient. And we take out the rash and we sent it for the fungal culture. And when we done the fungal smear, what happened? It came in like a septate hyphae. As we suspected, it was aspergillosis. We initiated him on voriconazole. And as far as we have initiated him, the patient should show the improvement. But the patient is not showing an improvement. He started developing he came after like 2 weeks later. He came and then he told like, I'm having a burning micturition and I'm having a little bit of, like a black color thing on my nose. Black color thing on my nose. Then immediately we suspected like it might be a mucor because he's a post-COVID patient. They might have induced him on a steroids. Then we need to give him a fungal culture again. There might be an error in the lab. Okay, so we have taken 2 samples, one from the like a burning micturition part, which is a urinary tract, and another one from the nose. And both part had shown one on the septate hyphae, another one showed a aseptate hyphae. Another one showed a aseptate hyphae. Surprisingly, we are surprised that this patient simultaneously got 2 fungal infections. One on the aspergillosis on the urinary tract, while mucor on the nasal area. So for him, we did multiple procedures because he had developed the further complication and he got the renal stones. We had put him on the DJ stenting and we have put him on we have done a test for him to remove the mucormycosis. And then we have initiated him with the voriconazole and like a liposomal amphotericin B. And the problem with the amphotericin B is like he can develop a kidney complication. Yes or no? He can develop a AKI. So all of the things has been managed, and after 4 months of aggressive treatment, he came back to normal. But everything has been vanished. Quite a very interesting case. Sometimes, maybe after sometimes, if you're in the WhatsApp group, we may share the case history. It is in the, I will share you after that. Okay, sometimes. Then you have the Sporothrix Schenke, where you see the rose gardener's disease. Sporothrix Schenke, which is a rose gardener's disease, where you see the, like whenever your skin has been, torn off by the rose thorns, that is the time you may see it, the rose gardener's disease. Then you may see the parasitology, Trypanosoma cruzi, African sleeping sickness, and Chagas disease, Toxoplasmosis gondii, Toxoplasmosis, Trichomonas vaginalis, foul-smelling greenish discharge. Very, 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 very important MCQ. Foul-smelling greenish discharge, Wucheria bancrofti, elephantiasis, cholangiocarcinoma, clonarchis sinensis, seizures associated with the neurocysticercosis, where you see the consumption of uncooked pork, and Taenia solium will be the organism. Then you have a bladder, Schistosomia hematobium, liver cyst, Echinococcus granulomatus, which is a hydrated cyst, which is a honeycomb appearance you may see. Microcytic anemia is associated with the Ancylostoma duodenale. Myalgia is associated with the Trichinella spiralis, and B12 is associated with the Diphlobothrem latum. Diphlobothrem latum. So these are the things which is important keywords you may see into the mycology and parasitology. Mycology and parasitology. These are the important highlights in the microbiology, which you have to know. There are a lot of things we have discussed. So remember, people, so take this PDF and make a flowchart like this, and in the A3 sheet, make it and try to write it on your own. Mug it up and write on your own. Write on your own and make sure you master the sheets and make sure your micro is very good, because technically you may see it in the medicine or you may see it in the surgery. You may see it as a communicable diseases in your PSM. This micro is also one of the hidden gem where you may expect to see lot of questions, people. That's why I pulled this much stress to make a microbiology a good and easy one. Hope it helped you. So tomorrow we'll be having a holiday, I guess. 13th is our holiday, and 14th we can able to resume our pharmacology. So pharmacology, PSM, medicine, surgery will be the upcoming session, and then you may get one more break, and then you may get into the obstetrics and gynae, and then clinical subjects. Okay. So far we have done your patho, micro, anat, physio, biochem, anesthesia, dermatology. Nearly 7 subjects were done, and almost like 90 marks of MCI has been covered. Among that, your score should be at least 50 out of this 90. Okay, make sure you scored at least 50 to 60 out of this 90. Okay, clear about that? Clear about that? Okay, so all the very best, and see you tomorrow. See you day after tomorrow with the pharmacology. Okay, have a nice day, people. Read, and already they had mentioned about the PDF link. Whomsoever requested PDF, they can download it on there. Okay, on the comments you have the link. You can click, you can tap on the link and you can download it. Okay, and I recommend that Survival Kit 2.0, which has the additional MCQs. You can able to read that MCQs also and try to solve them. When you try to solve them, you can able to understand most of the things. Okay, all the very best. See you again tomorrow, day after tomorrow with the pharmacology people. Okay, thank you everybody.